Okay, what is this now? Yeah, okay. Go on, start down. Okay, azygous continues. So what is it? Interrupted IVC. Yeah, that's the right answer. Okay. Next. Answer. This is the superior vena cava injection. Post Glenn. What else? What else? Right sided Glenn. Fine. But what else? You have to comment slightly more. Post Glenn anyone would say, but what else is there? Important point. Is there a forward flow? Does the right ventricle has a forward flow? I mean, whichever ventricle, single ventricle has a forward flow or not? Can you see a negative washout in this region? Yes, that's exactly, that's the right thing. So whenever you explain this angio, describe this angio, you have to describe the whole thing. Like it's the right superior vena cava injection, and it's a Glenn shunt, right superior vena cava connected to the right pulmonary artery with a forward flow through the pulmonary outflow there is some forward flow because there is exactly this is a pulsatile right sided Glenn. That's the correct answer. Alright. Next we have what is the diagnosis? What view? The first question is what view and what view and what is the diagnosis? What is the diagnosis? What view? RAO view, that's right. So what is the diagnosis? It has played enough, it doesn't want to play anymore. Image is breaking, okay. Absolutely correct. Infundibular PS with BSD. Most likely it's a tetralogy of Fallot. Okay. Is the image is clear now? I'm sure it is clear. Okay, for the next one. This is a Pigtail catheter in the ascending aorta. You need to tell me the diagnosis. Quick hands on the keypad, please. Yes, correct diagnosis. Srinath, correct. It's a truncus arteriosus. Alright. If I would say this child is 3 years old, then would you recommend surgery in this patient? Yeah, but before saying no, Deva Prasad says no, but what, everyone says no. Yes, PVRI. PVRI is the one you have to calculate. Before telling a no to this patient and before telling make the patient go on medical management, we should know what is the PVRI. Correct. Recently we operated on this patient, PVRI was calculated. We did, there is a chance of false PVRI, of course. So we did a calculation of PVRI and then this patient was operated and he has still now moderate PH. The issue in these patients is if they grow older, even you operate on these patients, the pulmonary hypertension, although the lesion is repaired, pulmonary hypertension, little bit of pulmonary hypertension always persists. There is persistent pulmonary hypertension which remains even if you keep them on very optimal medical management with sildenafil, bosentan, whatever you do, but little bit of pulmonary hypertension remains for a very, very long time or rather lifelong. Alright. Okay, diagnosis. Next angio, diagnosis. and probable age of this child. Probable age of this child. No, that's not the diagnosis. Someone has written TGA, CTGA. CTGA is correct. TGA is not the correct diagnosis. Please see the Angios Quiz, please. And what is the probable age of this particular child? It is not a corrected TGA. It is not a corrected TGA. A TGA LV regress. Yes. So why this angio is being done, and why 6 months? No, not 6 months. Maybe slightly lower than that. See, the whole purpose of this angio was to take LV pressure. LV pressure to find out whether TGA more than 3 months. That is probably correct. Ashish is right there. TGA more than 3 months. Yes, that is the reason for this doing this cath, and angio was just like that taken just to demonstrate the anatomy. But the main purpose of this particular catheterization was, if the child was more than a month old, actually in actual facts, the child was more than a month old, LV was looking regressed, and we did a balloon atrial septostomy. Mind you, doing a balloon atrial septostomy beyond a month is slightly unrewarding because the atrial septum becomes slightly more thickened, and sometimes of course we get good results by tearing the flap. Like this child, we had very good results by tearing the flap, and this particular catheter is from the via the PFO into the LV to check the LV pressure, whether still the child deserved an arterial switch or even a rapid two-stage switch. That was the purpose of taking the LV pressure. So this child was just more than a month. All right, good. Just hold on for a second. Hold on for a second. Yeah, what is the diagnosis in this patient? Any guess in the diagnosis in this patient? No. Okay. The second, Ashish, you are very close, but you need to add some adjective to your diagnosis. No, it is not a classical BT shunt. You can't see the branch PAs, right? How can you all call this a BT shunt? Blocked. That's the correct thing. There is a BT shunt which is blocked. That's the correct diagnosis. So you can just see the stump of the BT shunt, isn't it? Yeah. So now we do a local heparin injection and then do a serial balloon dilatation, and then you see now how nice the BT shunt is flowing. This child ultimately went for total repair. All right. Now next patient diagnosis. It is a lateral injection. Yeah, valvular PS is very right. There is a doming pulmonary valve, but there is also an infundibular component with the post-stenotic dilatation. So all of you are right partially. But everyone is given one part of the answer. Srinath, Devaprasad, and again Srinath. So it is basically valvular PS, pulmonary stenosis with some infundibular component with a doming pulmonary valve with post-stenotic dilatation. So what is the ratio of the balloon to the pulmonary valve in this case? If you decide to do a balloon pulmonary valvuloplasty, 1 to 100 to 100, right? Yeah, correct. So that's the balloon being done. All right, go on to the next. Okay, diagnosis. This is a 7 days old child. That's not the correct full diagnosis, Prashant. You need to add something more. PDA is not the full diagnosis in this patient. That is a PDA, definitely there is a PDA. What else is there? Full diagnosis for this patient. Anyone? Yes, pulmonary tissue, ductal dependent circulation, ductal dependent pulmonary circulation. Yeah. So what would you propose for this patient? What treatment would you propose for this patient? This is a 7 days old child. Ductal stenting, that's what you have done in this patient. What else? Or a neonatal VT shunt. Yeah. So, yeah, of course, this patient is on prostaglandin because you can see a very large ductus, and you see one stent is there. What is the basic philosophy of ductal stenting? The principle is that you should cover both the ends of the ductus when you are doing a ductal stenting, because the ductus tissue is a very contractile tissue and spasmodic tissue. It can anytime go for spasm. So you have to cover both the pulmonary end of the ductus and the aortic end of the ductus properly, otherwise it goes into spasm. If you see, this is the first stent here, and the second stent starts from the end of the first stent and comes right into deep into the aorta, descending aorta. Because when we put the first stent, the patient was initially alright, then suddenly the patient deteriorated. So we did an angio and found that the aortic end of the ductus, aortic end of the stent was slightly pinched off. So we again recrossed the stent and put another stent so that this side opens up. This patient has gone for his second stage repair. Okay, now what is the diagnosis in this patient? Quick diagnosis. This patient is cyanotic. Pulmonary fistula, absolutely correct. What is the treatment modalities in this patient? Pulmonary fistula, they are usually multiple and might affect a lot of lobes in the lung. What are the treatment modalities in this patient? All right. But surgically, this patient had undergone initially a surgery of the right upper lobe. You can see some surgical stuff in this right upper lobe. You can see some staplers there, surgical staplers. But this patient continued to have recurrent problems. He underwent a right upper lobectomy, but the recurrent problems. So this is the second presentation of the same patient. So this is the time we put several coils in the left lower lobe, left, middle and lower lobes, and we got rid of this problem. Okay, diagnosis: 18 years old girl with severe MR. 18 years old girl with severe MR being followed up as rheumatic mitral regurgitation. Correct. That's absolutely correct. Stachynosis disease. Very sad part is this patient was being followed up as rheumatic mitral valve and was posted for a mitral valve replacement. And then when he went for the pre-surgical echo and stuff, the pre-surgical examination, it was found that the patient doesn't have a proper pedal pulse. And then a detailed echo and Doppler of the descending aorta, everything showed that there is diffuse narrowing of the descending aorta. So any mitral valve regurgitation, do not just look at the mitral valve, look at the whole of the heart, and clinical examination of the patient is very, very important. Like this patient was, when we went back into the history, was on rheumatic mitral valve treatment for almost 5 years, and she was, when this MR had really increased, she was posted for a mitral valve replacement. That is not done. And then this particular narrowing of the descending aorta, this was stented, and gradually the left ventricle function improved, and the MR also came down significantly. So she did not need a mitral valve replacement at the end of the day. So that's nice flow to the descending aorta post stenting. Okay, diagnosis now. Yes, Dev Prasad Srinath. No, both of you are wrong. Sorry. See carefully. Sorry. Okay. Please see carefully. It is not valvular pulmonary stenosis. It's not peripheral PS also. You can see the peripheral branch pulmonary arteries very nicely, and there is good vascularization of the lungs. See, the angio doesn't want to give you more time for diagnosis. It closes on its own. It is supravalvular pulmonary stenosis. You can see the supravalvular area is very narrow, just beyond the valve. The valve leaflets are so nice. You can see them. You see, there are discrete, nice leaflets, but the supravalvular area is absolutely narrow. This area, if you see carefully, this area is seriously narrow, and there is no post-aortic dilatation in this patient, which is usually not there in case of supravalvular PS. So this is a syndromic child with supravalvular pulmonary stenosis. Okay, diagnosis. Big heart, 10-month-old child, presented with lethargy, refusing to feed, and correct, is anomalous left coronary artery. Okay, very good. So the purpose of showing this angio is any patient, there is a right coronary angio showing the retrograde filling of the left coronary artery. Purpose of showing this angio is that any patient coming with the diagnosis of dilated cardiomyopathy, we should look at the coronaries at all the visits of the patient. Like dilated cardiomyopathy will keep coming to your OPD, the same patient will keep coming to your OPD for medication adjustments to check the EF. At all the visits you should have a definite look, careful look at the coronary. Because there have been reports where down the lane people have discovered anomalous left coronary artery. So that is very mandatory. Any case of dilated cardiomyopathy, please look into the coronaries, and also don't forget the arch for coarctation. And recently we had a patient, about 15 years old girl, in which both the coronaries and arch was normal, and just on the first follow-up of the patient, she was found to have long segment abdominal coarctation, which was not probably not a tachyon. It was very limited lesion. I mean, not other arteries, renals or subclavians, nothing was involved. But that's how, so your mind should always be open on these cases which have lot of differential diagnosis. Okay, now diagnosis in this patient. I will show you one more view. You see this image very carefully. I will show you one more view before you comment. This is the first angio. Next angio. Okay. These are the two angios. Now you tell me what you think about the diagnosis. Yes, I think that's the right diagnosis. Yeah. So this is from the left coronary artery. This is sometimes mistaken as somebody might mistake this as pulmonary artery, but you see this doesn't have the proper pulmonary artery distribution, because this patient, this right upper lobe is not at all filled by this particular collateral. So this is sort of a coronary to pulmonary fistula, but ideally looks like a pulmonary artery arising from the coronary artery. Okay, diagnosis. I'll show you one more view of this patient. Okay. Now put together, you please tell me the total diagnosis one. Don't hurry up. Okay, hemitrancus. So it is left pulmonary artery directly connected to the MPA, and the RPA is arising from the aorta. Yeah. Yeah. So what has to be done is urgent surgical repair for these patients, because you have differential perfusion in both the lungs. Okay, diagnosis. Yes. Now, what would be your management guidelines for this particular patient? In short, in very short, you can just write what is the management guidelines in this patient. This Kawasaki's disease everyone has written, but the correct diagnosis should be giant aneurysm in Kawasaki's disease. Okay, someone writes lifelong anticoagulation, and someone writes CABG. Yeah, actually CABG is rather a very difficult problem. I mean, difficult to do in these very small babies, and the future prognosis is not very great when you do a CABG in these patients. So I think if the patient doesn't have major symptoms, we should do a very regular checkup in this patient, regular follow-up echo, and put them on aspirin and anticoagulation. Definitely we should put them antiplatelet and anticoagulation, that is aspirin and warfarin in these patients. Some school of thoughts even put them on dipyridamole, aspirin and dipyridamole, but definitely a warfarin should be there in these patients. Even the right coronary artery in this patient is also quite severely involved. Okay, diagnosis now. Yeah. No, that's not the correct diagnosis. It is not ruptured sinus of valve. Please see carefully. Ruptured sinus valve to where? Or where are you seeing ruptured sinus of valve? That's not the correct diagnosis. Something very glaring is there in front of your eyes. Absolutely correct. It is supravalvular aortic stenosis. So don't hurry up. There is no competition to write this. I mean, you have to win the quiz, nothing like that. This is the same thing which you do in exams. Hurry up and tell a wrong diagnosis. That is not the right way to look at these angios. Think and then write. It is the clear-cut supravalvular AS, hourglass deformity. Very clear-cut. So what is now think and write. What other angio should you take in this patient? And usually which syndrome is associated with this patient? Yes, Williams and PS, peripheral PS. So any patient who has supravalvular AS you should definitely do a pulmonary angiogram to make sure there is no peripheral PS. Excellent. Okay, now diagnosis. Slow, steady, give the answer. Don't hurry up. Obviously, this is a big boy. I'll just tell you a short history. Big boy, about 18-20 years old, had surgery before, and you can see there are. Okay, you tell me the diagnosis. A full diagnosis I need. Okay, I'll show you the next one. Please give me a full diagnosis. Now everyone has become very slow after that. Okay, post-Fontaine is not the full diagnosis. What else is there? Okay, Fontaine dextrocardia, agreed. What else? Something else you can see in this particular angio. The previous one, this one, that particular thing, yes, fenestration. That's the correct thing. And what are all these? These are all post-coil embolization. So this patient had several episodes of hemoptysis and had to undergo several sittings of coil embolization. Okay, fenestration. So this patient was desaturating with this particular fenestration. He was leading, even post-Fontaine, he had several episodes of hemoptysis and he was desaturating in the level of 80. What would you recommend? What would this patient, 18-20 years old, getting readmitted with several times, and yes, check PA pressure, cardiac output, that's right. If those are all right, if the PA pressure is normal, then you need to do a Fontaine fenestration closure. So we did the Fontaine fenestration closure. The saturation improved to more than 90%, and we have done this about 2 years back. Saturation of the patient is more than 90%, and following that, the patient is doing very well. Didn't have any further episodes of touchwood episodes of hemoptysis needing coil embolization. But this is definitely a chronic problem. Okay, see this angio very carefully and tell me what is the diagnosis, what is the comment on this particular angio. I'll freeze it for you. Okay, right. Okay, what else? Tortuosity with coarctation, yes, but what else? Something else? Something else? Some other spice to the diagnosis? And any other comments? Srinath? Ashish? Who else are there? Only please play. Okay. I guess that is okay for now. Okay for you now. Yeah, so what is the answer? Severe coarctation, aneurysmal precox segment. Yes, so what is the aberrant subclavian? No, that is not right. There is not aberrant subclavian. What is the procedure which is supposedly, what procedure has been probably done in this patient? What procedure? Dissection flap. So what procedure was the question? Yes. No, maybe no. Usually in surgeries you don't see this sort of aneurysms. It is probably a post balloon. It's probably a post coax balloon, and you can see a nice aneurysm. So this patient, if it comes back to you, definitely don't recommend repeat balloon coaxoplasty in this patient. Only option for this patient is surgical repair. Okay, diagnosis. Next patient. No, this is a small child. Why will you put a stent? This is a small child. You can see by the angio itself there is a small child. Yeah, covered stent is an option in this previous patient, provided the patient is grown enough. Otherwise, please send this patient for surgery. Okay, diagnosis in this patient, in this angio and the next one. Okay, full diagnosis. Full diagnosis, please. No, see this angio doesn't look like an intact IVS. This looks like more like a single ventricle. If you see the quality of this angio, quality of this ventricle, there is small septum in between here, and this looks like more like a single ventricle pulmonary atresia, isn't it? And it's a pulmonary atresia, and there is a severe stenosis of the left pulmonary artery. Ductal dependent pulmonary circulation is alright, but a severe stenosis of the left pulmonary artery where the ductus insertion, at the site of ductus insertion. This patient is say 6 months old. What would be a recommendation, surgical recommendation for this patient? 6 months old. 6 months old, single ventricle with such a pulmonary artery anatomy. What is your recommendation to the surgeon? Quick answers, please. BDC, left BT shunt with PA+T. Both are actually correct. This is a matter of debate because the left pulmonary artery is not so great. So even if you give a PA+T in this patient, probably Glenn might not take it because of this diminutive size of the LPA. So you might sometimes do just get away with the BT shunt and later on quickly in next 3-4 months do a Glenn. But the other flip side of the coin is that if you do a BT shunt in this patient and do a good PA+T also, there is chance that the PA pressure might be slightly on the higher side for the patient to become borderline for a univentricular line of repair. So both the recommendations which you have given are partly correct, partly incorrect and incorrect, and probably depends on the particular institution what exactly their surgeons are comfortable with and what exactly you look in the long term. Okay, last angio for the day. Please think carefully and give a good diagnosis. One diagnosis, not in parts. One diagnosis, not in parts. Good. That's fine. So this is a tricuspid atresia with restrictive VSD with pulmonary stenosis. Great. All right, everyone agrees to that? And thank you. I am sorry for all the problems which happened, technical problems. All right, thank you everyone. See you next time.